Bogi, hi, and thank you so much for joining me on Faces of Digital Health for a discussion on the global impact of digital health technologies for your years-long efforts to make healthcare more sustainable and to contribute to better health outcomes. You are a keynote speaker, you're a change maker, and in your talks you often ask politicians or policymakers a question whether or not they want to have a good healthcare system or do they want to have a healthier population. So let's start with that. Who has heard you so far with that message? Where do you see that people really get what you mean when you say that?
Yeah, thank you so much, and also thank you for hosting this interview and all the things that you are doing as well on pushing. So thank you. On that question, I think this is a question I've used for quite some time, and the reason is very simple. It is not that you only do one or you do the other, but you need to choose what is your driver. And when we think about health generally, often we want to imagine that this is about a good long life. So being as healthy as possible for as long as possible, but that we also have some tranquility and quality of life in it. Now, what has happened over the last 100, 150 years is that we are becoming very focused on what do we do in acute needs. Originally, this was communicable diseases, accidents, and violence, where you need to act very fast. And of course, we need to have that part in our society. But with time, we have evolved our expertise to become almost only focused on acute. So we are not helping early and keeping people as healthy as possible, which we actually could do with technology, if that was our purpose. We are, as human beings, compassionate in a way that we always want to give everything we have when there are crises. But most of the crises we have in health systems today are because we are not acting early. So if we act early, we could probably reduce just for chronic diseases, 30% of the suffering that we have, but also 30% of the run on the health system, which again means that if we acted early, we would not have a crisis in the healthcare system.
Mm-hmm.
Go ahead.
Can you maybe expand on that thought a little bit, especially on chronic diseases? Are we talking about, primary prevention? Are we talking about secondary prevention when people are already managing their disease?
Yeah.
And, some people do better than others. People experiment with many things due to chronic conditions when they give up on the healthcare system or because they don't have access to the healthcare system. And then they rely on unproven or less traditional medical methods to try to turn their health situation around.
Yeah, in the best of all worlds, we would talk more about primary prevention than secondary prevention, but right now we are in a transition, so it's not the best of all worlds. So our focus is on secondary prevention, meaning how can you help people at high risk for a chronic disease? Or how do you help once you have a diagnosis to reduce the progression of disease most possible? So, for instance, in diabetes, if you follow the guidelines and you have life circumstances that allow you to change your lifestyle, if that is necessary, you can actually live quite well with diabetes. If you're not doing it, the consequences are quite severe. So the secondary prevention also has the other thing in it that with age, with time, we normally do not just have one chronic disease. We have several chronic diseases. So the background thinking when we began to work with this was to say, okay, we gain lifespan. So over the last 30 years, we have gained more or less 10 years if you look on average. but half of those come with extra disease burden. And my naive question is that necessary? Is it really so that just because we get older, we need to have more combined disease burden? Why can we not get older and keep the disease burden in your lifespan the same, which means that you get more healthy years, which should be the point.
So how do you actually achieve that, knowing that a lot of the disease burden comes from lifestyle factors, and any time, which also means basically the food industry, the sugary drinks industry, and anytime healthcare ministries or governments try to either create taxes to make those foods less attractive, there's a huge backlash from the industry. So it's not as much as about the decision makers not knowing what to do. It's more that it becomes a political issue that sometimes fails to conform to the industry expectations.
Yeah, that is the million-dollar question. It is not to convince people what we should do. It's how to do it and why. It does have several constraints in the way that we are thinking today. We are thinking fairly short term, not just because we have short political cycles. We also have very short business cycles. So you change leadership in the big companies very frequently, more often than you change politicians, actually. But we also have different kinds of bonus schemes, which are very good for some things, but can be hindering in thinking long-term sustainability and impact and outcomes of it. So there are many constraints in that way. Now, if we want to change this, we would need to build cross-dimension collaborations. So meaning that it's both public, private, philanthropic, civil society, but also on an individual level. It is a new understanding of what do we need. One place where this driver comes from, and we should also be very humble in thinking what is it that can provide the change and not be too linear in the thinking. So one push that is coming is from the environmental impact and climate change. So health is the 5th biggest polluter in the world. So that is being addressed in many systems. And there are two main ways you can do this. You can make everything green, which probably will help a bit. But maybe first you should think, what are we doing in the health system today we should not do? Because making a unnecessary service green is not sustainable. You're just making something a little bit less polluting. And one way to address that is to say, okay, if 30% of the disease burden is totally avoidable with the knowledge that we have is just a change management, then maybe that is the most impactful thing we can do. So there you both would solve the unnecessary or avoidable burden of disease, but you would also work on a bigger climate issue on it. Then your question, is this interested for the industry, as you asked for? I do think that we are on the verge of a bigger paradigm shift where you're not just in health, but in general need to rethink what provides value and what is then the business. And it's quite clear that we, over the last 10 years, have been thinking about both the triple and quadruple and 5 bottom lines on what is your impact on society and the globe as a whole. So that train is running. But we also need to embark on that train from the health system approach. And here there are some very difficult things, because you always have acute things to deal with in health, and then you have the long term, which then also has an impact and drives some of the acute needs that we get later on. So how do you drive that balance between the fire right now and the need on the future? And that is where we really need to get the stakeholders together and find some kind of a balance in it. And one push that is coming is the European Health Union idea, how to work with those things, but it's still in the making.
Okay, so let's talk about use cases and ideas where this is already getting in practice. The Nordic Health 2030 vision calls for a paradigm shift from reactive care to preventative, data-driven health systems. You helped launch this movement. So, where is the movement at the moment, and how are you translating the principles to the global stage? As you are also working with organizations such as the WHO and the Movement Health Foundation, which you took the leadership of in May last year or this year.
Yeah.
Was it this year? Was it
Yes.
this year?
This year, March this year. That's fine.
Okay, so you're
So,
fairly
uh,
fresh.
yeah, it's very fresh. Yeah. Yeah. Let me start with the origin of Nordic Health. The Nordic Health approach was based on we in 2015 did a deeper Danish scenario process with several of the main stakeholders, both public and private. In how do you work with this new technology that is coming? So that was both data and genomics and others in that way. And one of the conclusion was that it needed to become much more preventative if we were to be able to both to fund it, but also to find the human resources to work in it, because there was already at that point quite clear with a fast growing disease burden, or at least demand for health services. But one of the conclusions was also that one country of the size of Denmark was too small to deal with this. So it had become first stage Nordic, and then you could consider that part. On a personal level, from my side, there was also another driver in it. And that was the huge shift we were beginning to see from an analog to a digital system. What does it mean for a solidarity in a health system? Because a health system is in principle a risk sharing. You pool your resources together and then you help the people at the point that they need it. And when you have an analog system, you are more naturally bound in your jurisdiction, being a region or a country, and you have that idea on how do you risk share. But when you become, I don't know, 30%, 50%, 70% digital, you're not bound by the geography anymore. So what does that do to the social contract and the solidarity in it? And this is becoming an even bigger question now than it was at that point, because it deals with when you work analog, you take the learnings in the system all the time and you try to develop over time. The potential to do that with digital is much bigger, but then you need to figure out who are you helping? And that's not what has been happening. We have been fragmented to think in a digital approach. So a huge component of the groundwork of the Nordic was to say, okay, if we believe in the Nordic way of doing health, solidarity is a ground pillar. How do you secure that in a digital world where you go cross-border all the time? So that just to explain that this is a question that has not been solved, but still is in the making. You could see that you see fragments of it in the European health data space, because then you try to give at least access to secondary use of data in many ways, but we're still missing what do we do with the primary use of data and developing the health systems. So that was one of the parts raised on the Nordic Health. The first phase of Nordic Health that we then started in 2019 was in its origin very much based on digital and genomics. But we also learned quite fast that if you want to develop these drivers over time, you can't be too focused on the technology, but rather on the values and principles, because technology changes so fast. And then also the persons that you would work with also changes very fast. And really looking at building resilient system, it was clear in our calculations that there was no way that you can fund the fast growth in disease burden and also avoidable disease burden, because the systems had become demand driven in a way that you just respond to more and more disease rather than going to the root causes, which should be justified by all the data and technology that we are investing in. So here the question came in on saying, okay, can we change this dynamic by saying, okay, half of the budget should go towards more primary, secondary, and tertiary prevention, and half still stays more traditional curative in a phase of trying to change the focus. And in the Nordics, it's not even a question of if you can fund the growing disease burden. Probably you can, but the health professionals to deliver the service do not exist. You can't find them. So it's not even an ideological question on can you or can you not pay or how much money you should. You simply you can't respond to the demand. So it has to change. So that was one part of it, and then then of course there came the small bug, COVID, in and changed a bit how we could work with the next phase. But then when we started in 23, it was very focused on how do we then move from having the direction to being more applied on making practical approaches, which is then what we are trying to push forward today on that part. The idea of the philosophy of going more preventative has been taking ground, I would say very broadly, not just in the Nordics. But it's also very important to say that it is not paramount if you reach certain percentages, but that you begin to work much more on solving the issue as early as possible, but also with having dignity as a driver. So you work with people. So we have for 20 years said that we want to be very person-centric. But person-centric doesn't mean that you just tailor a technology to a person. It actually means that you integrate the person in the process. And this is what we are also trying to lift with having dignity as a concept when we work forward with it.
You're based in Denmark. What are some of the principles that the healthcare ministry or the government are taking there that you could mention as something that you are either proud of or see as a good example of practice? What I found interesting when recently was to know that Denmark actually has a ministry dedicated to the elderly. So that just shows how seriously you take the topic of the aging population. The digitalization also has a very long history, and new health reforms are now going in the direction of making the most out of that data. So, yeah, can you expand on that?
Yeah. I think there are many good examples to take from Denmark. There are both concrete better results, for instance, in cancer care. But I think the most important thing here is that the last 15 years, Denmark was very focused on a super hospital approach, which made very efficient big hospitals, which is good to some degree, but it only solves the half of the curative part. Now the new health reform, which is being rolled out, which I think is very, very interesting, concludes that if we really want to work with better population health, a lot of the work has to happen outside of the hospitals. So now the process is going the other way of, you could say, more having hospitals as a backbone, as well as, of course, having the more invasive curative parts, and moving the point of entry for patients to be as early as possible and where the complexity is as low as possible as principles. And connecting much more with the local level, being municipalities and regions, to solve it, and also realizing that the specific clinical side of the intervention is only one part. You really need to think about the general life of people, and this also comes into your question that you also said before. There are so many other things that impacts a person's life, and I do think that is a part of what we see in the Danish health reform. And of course, it's being rolled out now, so we don't know if it works, or beginning to roll out now. But mindset-wise, I do think that this is one of the most promising things that I've seen for many, many years in that part. And then the private-public partnership relation in Denmark works fairly well. I'm not saying it could not be better, because these are still things that needs to be developed quite a lot. But I do think that that's one of the dynamics that is to learn from.
So what do you think about the public-private partnerships? The reason I'm asking that is because across Europe we see the trend of shifting expectations of clinicians in terms of their work-life balance. Younger generations are not willing to basically sacrifice their personal life for medicine anymore. So some are transitioning in the private sector. Healthcare systems are adapting in a way to allow them that to happen, but still keep clinicians at least partially in the public systems. So what would you say, based on your experience working with the governments, around that trend and the move forward?
Yeah, I think that we need to redefine that understanding of health, because health has over the last 50 years become sick care, not health in that way. Let me first take the question on private-public partnership. I, as a person, I don't really mind who delivers the service to me, who is involved in the service, as long as the frames are made in a reasonable way, so that I get the best possible outcomes of the service that should be provided to me. If that last mile provider is public or private, I don't really mind if the playing field is just and is also made for the society. So both for the personal outcome, but also for the societal outcome. If the data is produced by a private provider, I shouldn't care about that. So I think we need to redefine the playing field of saying, okay, this is what we want out of it. If it's a public or a private institution that provides it, should be less important. Also, because the difference between what is public and private, just if you think about Europe, in between countries, is very big. So you can't just say that we have a European public and private part of it, and we would never find an agreement on that. So I would rather go the other way around. And say, let's build the playing fields. So we are doing some of that with the AI Act, with the European Health Data Space. There are some of these things coming in. Now, where we have the biggest challenge in making this change is the incentive structures that we are providing. So the incentive structures that we have today are mostly for curative and for activity, mostly. And that doesn't change anything if that's a public or a private provider. They still act in the same way because we pay in that way. So we need to change that ground part of it. And then your question on the workforce that is changing, which also connects to the huge burnout that we are having, has several different components in it. One thing is that the way we articulate health is dealing with acute disease. The way we recruit for education and health is to be one of those personalities that can deal with acute need and help people. The way we train is for the acute. The way we hire is for the acute. The work that you need to do is 85% non-acute. So there's a huge mismatch between what we are recruiting people for in combination with what we really need as a society in that part. So that I think is a quite important thing to take in. And then why should we expect that just because you work with, just in brackets, just because you work with health, you should not have a personal life, or you should just sacrifice everything? It's in all other sustainable thinking, you would not think this is logical. So why should we have that? Of course, we need normal working conditions. And does a person really provide better value because they work 80 hours instead of 40? I don't think there is any evidence that shows that. No,
but it's a cultural change. It's a bad tradition that needs to be broken. That's the issue, I guess.
Yeah.
If we go back to digital and how digital can impact healthcare for the better, the Movement Health Foundation that you're leading has piloted digital health projects across various countries. Can you talk a little bit about that, the global footprint projects that you're running on different continents? How do you even choose where to go and what you will implement or recommend there?
Yes. Thank you. And first, I need to take a little bit on the background of that work. It started in late 2019, based on only working with Latin America, because we had a question with collaborators there. Why are the health systems not progressing faster, given that the economy had progressed and there has been a lot of funding to improve health systems, for instance, from World Bank and WHO and International Development Bank. And there we also learned that even if the general perception was lack of money, we learned that many of the systems did not have the capacity to execute the money they had, even if the budget was low. So it was much more a structural challenge. So we went in and established this Movement Health as a non-for-profit organization with partners, in working both bottom up and top down in doing demonstrations, pilots on improving health on the ground, and at the same time framing the system more for the future. And a part here is really to say, so how do you work in a low and middle income reality, having in mind that almost any health development that we have, or health technology development that we have, being pharma products, being medtech, being AI, is primarily focused on the richest 10% in the world. And that this is, of course, a challenge. So how do you adapt this to realities in different ways? And that's where we also have tried to go in and say, okay, what can you do in these societies where you still need to improve health quite a lot? And if we then go to what we're doing, because we then learned that this was something that had a need in other places in the world. So we are active in Africa and Europe, and already pushing a lot of that part forward as well. But for instance, in Mexico City, we have worked with the health administration that is responsible for almost 10 million people, 35 hospitals, where we have helped them to work with data in a way that could be much more real time. So going from having very siloed and fragmented data in many different sources, to align that with AI gives an opportunity to that you much faster can clean up data. You don't have to spend a lot of manual time on it, which was the case, and have real-time dashboards, both for decision makings, but also to see activities for each of the 35 hospitals that you're in. So it moves the ability to work with strategic decision making from being very difficult to actually having real-time data. And the beauty here is, and this is the core point, we are not doing new things. We are applying what exists in new contexts. So in that sense, you could say the movement health is quite boring. Mm-hmm. So our innovation is implementation innovation and behavioral change innovation. It's not product innovation. So we are not doing any innovation from scratch. I would take another example from Ghana, where you have a admitted very big challenge with cardiovascular disease, so hypertension in this case. And here you have a structure where the health ministry has an agency that is a pharmacy council, which is public, and then you have, like in most country, private pharmacy or pharmacy chains. So the idea here was to say, okay, we have a challenge. We are strained on resources to really build new things to solve that challenge. So what do we have? Okay, we have pharmacies all over the country. So here we have the first phase on activating 400 pharmacies, so really doing education for people working at the pharmacies. And this is not very intensive education, but still you need some. So you put a QR code on the wall in the pharmacy. Any person who walks in can take a picture of the QR code. Then a person from the pharmacy would take a blood pressure test. Then if you're over the threshold, you get referred to a clinic or to a hospital. So no new stuff, no new technology, no new buildings, but a huge new opportunity in dealing with one of the biggest challenges for the country. In Peru and in South Africa, we are pushing for cervical and breast cancer screening, especially in areas of low resource, so people who normally would come very late into treatment for these cancer types. And these are cancer types that if you get early intervention, you can actually with a fairly low budget get people really good of the treatment. So there's a high impact compared to if you go in late, where the treatment is both very expensive, but the impact is very limited compared to if you get in early. And one question here, the most important question is, how do you help more people? But it's also about how do you help more with the budget that you have? So there is an allocated budget for the treatment. So let's help as many women as we can with the budget.
Scaling is definitely a big question in healthcare, a challenging one because of different data sets, different cultures. And I guess to which extent, when you do projects across borders, to which extent do you actually have to start from scratch, and to which extent can you use what you've proven in a different country? We talked about Africa a lot. The healthcare systems there are a lot different. Usually the people I spoke with about Africa so far say access is not the problem, because actually the nursing workforce in the communities is well spread out. However, the quality is a bigger issue, and the doctor ratio is also super small. In some countries, it's if for example in Europe the number of clinicians is 2.8 to 5 per 10,000 people. In Africa, it can be 0.1, which really shows the lack of workforce. So how do you deal with those differences when you decide to implement a new project in a specific country? And how long are these projects usually, given that implementations in healthcare can be a few years long?
Yes, thank you. So here's probably where I take a different approach than most people. To me, the health systems that we often look at, for instance, when we go to HIMSS and other places where we meet, are very high level, very expensive, but also quite inefficient health systems, despite of all the technology that we have put in. One challenge here is that we have applied very advanced technology onto an analog process, and often analog processes that are broken on beforehand. And I think the president of HIMSS, Halwolf, normally says that putting new technology on old thinking is just going to be very expensive on that part. And the question for us here is, what are we trying to solve? Right? Are we trying to build better health systems, or are we trying to have better population health? Right? And even if at some point you need to think about both, one of them needs to be the driver. And for us here, the health outcomes is the driver. And the countries we are talking about here, in the low and middle income countries, they should not do the mistakes that we have done in the richer countries. So you need to learn from the successes and the failures. And one of the failures is that we have focused too much on very advanced treatments, very late stage, and very little on what can you do early with knowledge that we already have. So this is what we are trying to approach here. So when you compare the doctor and nurse ratio, that is a good thing to do, but we need to think, what do we want to do with them? And what happens, for instance, in Latin America, which also was a surprise to me when I started working, is that the real thinkers and decision makers, they are not thinking about very advanced super hospitals. They are thinking about, how do we make the best possible primary care? And I do think that the change that we need also in the richer part of the world will not come from the richer part of the world. It will come based on needs. For instance, from Latin America, if you bridge the Spanish-speaking countries or the ones that use Spanish for health, you are already above 500 million people using the same language with very similar culture, so you can use digital interfaces at scale. In Europe, that is very difficult because of the language barriers, for instance. Africa is also very divided into different cultures and languages. So in Latin America, I do see this opportunity really being present. And here it comes back to one of my core elements that I've worked with for a long time and also push in movement health, is what happens if you put health in as the main driver of society, so the most important pillar. So today, when health is sick care, it's something you do when things have gone wrong. But in reality, health is a driver for prosperity, for well-being, for the good society. So how would you invest differently? How do you get different players in? Your question in the beginning was, how do you get the industry players in? You get them in by convincing that they have a role in building better society, because that also gives a bigger market for them in the end, even if they just want to take it from themselves. But of course, this is a long game. This is not a short game. The trajectory we are on with only focusing on the sick care will break down. There is no sustainability in it. So this has to change. It's more a question about, do we manage to change before we get a big collapse, and where would we see the change first? And here my thinking is that this is going to be in some of the middle income countries first.
Mm-hmm. Usually, when we talk about the transition from sick care to healthcare, we work under the premise that healthcare systems actually want healthier populations. I think that's absolutely valid, because if we expect people to work longer and to receive pension later, we also have to improve their health. In Europe, like the people spend 15 years with disability, and especially women, throughout their years, they face many disabilities. So a provocative thought that was shared to me by Michel Poulon, who's the researcher and the author of the term blue zones. He said that one of the policymakers said to him, Mr. Poulon, imagine that people lived long. Like, if people do not live long, I don't have to deal with healthcare, and I don't have to deal with pensions. So, if people have a longer life expectancy, that's actually in a way cheaper for healthcare systems. So how do you see that? Did you ever encounter such a mindset?
Yes. Yes. So to be a little bit provocative on these, of course, a thought when we do approaches like both Nordic Health and Movement Health is, who are the players that we need to have in, and who's free riding today, right? And who we don't see really coming in are insurance companies and pension funds. And they both have an interest in that people live long as they work. They don't have an interest in that people live much longer after they stop working, in principle. And this is something I always tell them. And this comes back to, how do we fund things in society? So in incentive structures. But there are also changes that we as a society need to think about, and I am really also missing that we get the labor unions into the game and saying, okay, how do we help our members, right? Because if we have gained 20 years longevity over the last 50, 60 years, you cannot expect to have the same retirement age. I mean, it is not reasonable to expect that.
Yeah.
We have also shortened the work week, and we probably will shorten it. But we also know, for instance, from research from Denmark, that only 10% of persons benefit by retiring from one day to another. It's very hard for a quite big part of the population, and it's directly negative for many, because it's embarrassing not to work full time until you're, let's say, 67, and the day you turn 68 is embarrassing to work. I mean, it doesn't really make sense.
Yeah.
So we also need to rethink that people need a person. You need to be with people, but you also need to have something to wake up for. If that's a paid work or not, it doesn't really matter. But you need to have content in your life.
Absolutely.
And that's also what the blue zones is showing. The one who live longer on that part. Then I would just myth bust some of the things that we have in these discussions, which the blue zone also is pushing on. So we have, our average lifespan has risen over the last 100 years quite a lot, 150 years, at least doubled, tripled in some areas. But the peak age, the one who become oldest, that has not changed, right? So when we have the discussion on that, now our average age has risen, and then the ones who are born now will become 200 years, it's because you don't know how to read statistics, right? So maybe we get some fantastic new intervention that will make everybody live much longer, but so far the technology has not prolonged our peak age. And I think that's very, very important to have in.
Yeah.
And then when we come in on your question, yes, it's much cheaper that people just die. This is why I think dignity as a concept is so important. So whatever we do, we need to put dignity in, and then it comes into another concept that we have worked quite a lot with, and is what is the difference between lifespan and healthspan? In reality, nobody is really interested in just living very long. You want to have a good life as long as possible. But probably by focusing on the healthspan, you would gain the lifespan with time, because you live better for longer. But there are some crucial differences that we need to focus on. So if you look at the Western health systems, you spend between 30 and 50% of the budget on each person in the last year, and with very, very little impact. It's more a desperation that you have to show that you do something. So this culture of you could not die or you should not die, probably we need to change to, okay, what is the impact of if we spend the same money we spend on each person on average today, but we figure out when it is best for the person's well-being to spend it, then we also need to be much more clear on palliative care, saying, okay, once you reach a certain stage, we don't do everything. And here, dignity to me is the core question, because in the end, what we need to get back to is, how do we leave this world with dignity? And that is not by going in desperation into treatment, which has no impact, because you strip off the last quality of life of people's life and giving them a right to go from here well. Saying, so we really need to change ways that we are thinking what health is in order to make this change.
And also basically open up the discussions and demystify the fear around death. We're not going to go into this whole discussion around, palliative care versus euthanasia, but I will say that I know many people that had their loved ones die either due to cancer or other illnesses, and what's common to them is that nobody that sees a person dying slowly, so nobody that doesn't see a person dying slowly will understand that just, holding on to life till the very last moment, just so the person dies naturally, is the meaningful or the dignifying way to go. There's a certain point where it would be more dignifying to just enable a painless death for an individual that will not improve health-wise, and it would decrease the trauma for that person and for their families. I don't want us to, go into a completely new direction, even though we could. But I do wonder, we mostly discussed challenges, which are obviously complex in healthcare. But if we think about the future and all the work that you're doing, what emerging innovation or policy shifts do you believe could most transform global health by...
Yes.
It's we like to say 2030, but that's in 5 years, so it's very close. So let's say in the next 5 to 10 years. And maybe you can also talk about some of the things that are a success in the last 15 years, because if you follow healthcare very closely, it can feel like nothing is changing and everything is bad, but we are making progress. It's just very slow.
Yes. So there are several ways of approaching this. So let me first set the stage before I go into the technologies. The last 10, 15 years, we have tried to articulate a new way of having a fourth industrial revolution, which then goes into have new biology. So genomics was first the driver, but then it's how do you work with the biological level, both to understand the expression, so you understand what happens, but also how can you manipulate and use biology as a tool. And together with that is also digital functions in many ways, and data. And of course, AI has been the huge changer over the last couple of years. And then with that, also smart materials. So you can also work with nanotechnology, robots, and different kinds of things. That part has been really focused on volume. So we activate 3% of health data we produce because we think about how much data can we produce, not what is the outcome of what we do. The same with the biology. It by some needs, because you also need to have mass to understand what is happening, but do a lot of sequencing, do a lot of tests in different ways. Imaging, which is also very important. We do a lot of imaging. So the change that I think is eminent to come now, and a huge opportunity, is not the technology per se, but rather how do you apply these technologies with outcome in mind? So this is what I phrase as the fifth industrial revolution in health. So how do you go from the quantity to the quality? So that, for instance, also requires that we change what we want to achieve. So that is the prevention side and healthspan, but also how do we pay for that? So we get that change. And one of the big changes in the technology would also be how do we approach it? Because we have had very linear approaches to, then we go very deep in some kind of new biology, saying sequencing, genome sequencing, or we go very deep in some data mining approach. But rather, this is about a holistic thinking on how do you have different sources of information that you then apply. So for instance, you radiogenomics, where you do imaging and genomics at the same time. So you have the biological expressions and you look at how the tumor grows or moves or all of these things. So maybe you would rather have 5 sources of more shallow information than one very deep, which likely is much more secure and cheap and achievable for low and middle income countries as well. So that is one way to it. And we will be revolutionized by different kinds of real-time monitoring. All our health understanding has been built on static data. But if you want to understand what is happening with you, you need to use real-time data. And there's only one person who can do that, and that's you. So so personalized will not just be that you receive personal information, it will be that you produce personal information. and how we can figure that out in a sustainable way, how to work with it, requires a new data model where you bridge the individual with the aggregated data. We have the technology. It's about the governance. How do we build the governance for this? So the European health data space tries to solve the aggregated part on access to aggregated knowledge, but it doesn't solve how do you get back to the individual to have the individual as a part with it. And this comes back to your first question, that there are so many other things that affect you. So we would in some years, we will have a digital twin in our phone or whatever we have at that point that would help you use existing data. So not necessarily producing new data, but it will be your own data that you produce, but with existing aggregated data that helps you manage your well-being. So simple example, which what already exists. If you are allergic or asthmatic, you can have an app that tells you that the direction of the wind and the pollen in the air tells you, okay, you should not go to that side of the city today, for instance. I mean, we have a lot of these things, so it's really about assembling what exists and apply it in new ways, which we then call the fifth industrial revolution. So the focus, I hope, for 2030 is not new technology, is new way of thinking. And we are trying to apply this in movement health by saying, okay, let's build digital bridges. No new buildings, digital bridges where we connect it. And here is also a focus on what matters. So what matters is moving the many a bit. So that's scaling what matters in that part. And of course, the AI and tech equality, data and tech equality needs to come in. So what we are missing a lot is the basic knowledge in many societies. So applying digital functions and AI, if you don't have the basic data, is not going to work. And now it comes back to the companies that you talked about. So how do we make prevention profitable? Today, sick care is profitable for many, but prevention is not. So how can we change that? And that, of course, requires that we focus on serving the person, not the system first. So the system would be the driver for it. And the tag word we use for that is always to inspire for radical simplicity. So how can you, go cut to the bone and say, what is the root cause of this? And then push that forward.
Yeah. The only thing I will add is that apart from thinking about prevention as profitable, generative AI is really making prevention and making good decisions accessible. I, as a chronic patient, continuously consult with ChatGPT around. I have a flare-up. Can I ease this? Can I take that drug and get all the information about why yes or why not? So in this sense, digital literacy and also exploring more and teaching people how they can use these tools to get at least some additional knowledge, I think it has a huge potential, of course, without undermining the awareness that this is still just a consultation or an assistant, and that for actual medical opinions, you need to see the doctor and go through medical procedures to get to the final answers. But I would say, that we are in an exciting time with these technologies, and this is something that I don't say quite often, since I try to understand problems more. Do you have any last thoughts in terms of what you're excited about, what you are currently working on with the Movement Health Foundation?
Yeah, so we are trying to build a very how can I say, courageous approach for Europe in bridging East and West in that part. And for Movement Health, and I must say this, we are always looking for partnerships in different levels, both public, private, philanthropic, because this is a movement of going forward together. Then on the part that you were just mentioning on how you use it as a chronic patient, the data. So what is possible now if you build reasonable frames for your work with AI, you can give patients, professionals, politicians, journalists access to data in different ways. So if you, for instance, have a validated pool of information, it's not that difficult to build chatbots that will respond to the level that you need, right? Or to the needs that you have. So are you a patient? So you could ask differently if you ask now as a patient, but you can also ask as a health communicator, and you will get the answers tailored for that. So for the health literacy, as you mentioned, we are only seeing the beginning of the possibility of different kinds of AI.
Well, Bogi, thank you so much for joining me for this discussion. We'll definitely continue, so keep me updated on the projects and the work that you do.
Thank you so much, and thank you for inviting me.